So today I want to present the cerebral venous thrombosis. We just take it as a case series, and I am Dr. Nguyen, come from the SA units in the S.I.S hospital. For disclosures, I don't have anything to disclose. And for the overview, as you know, for the cerebral venous thrombosis, we can target a CVT is a type of stroke where the thrombosis occurs in the venous side of the brain circulation. So that means the clot occurs in the outflow of the circulations and leading to the occlusion of one or more cerebral veins the dural venous sinus. And the thrombosis of the dural sinus and cerebral veins is uncommon form of the stroke, usually affecting young individuals. And despite advance in the recognition of the CVT in recent years, diagnosis and management can be very difficult, and some patient really misses in the practice. And the CVT represent for 0.5 to 1% of the all stroke. Multiple factors have been associated with CVT, but only some of them are reversible. So here we conclude some prior medical condition is happened for the CVT. Is the past medical history is thrombophilia, inflammatory bowel disease, and a transient situation. But here we take note about the oral contraceptive because it's happened in a young individual, especially for the female populations. So according to the largest cohort study, so we take it here is the ISCVT 487, so that means 78% of the patients occur in the patient younger than 50 years old. So in the series of the intracerebral hemorrhage investigations case in the young people, CVT explained for 5% of the all cases. So we talk about the clinical diagnosis. Here we take note in the two symptoms. The first one is the increased intracranial fractures attributable to impaired venous drainage, and the second one is the focal brain injury come from the venous ischemia or infection or hemorrhage. And we talk about the differential diagnosis. But we take note here is the how we differentiate with other diseases. So here is the characteristics. You can account for the CVT to difference with other disease in the brain for the cerebral. Like the first one in CVT, the headache is just focal and generalized seizure are frequent, occurring in the 40% of the patients. And the second one is the bilateral brain involvement is not rare. So that means it's very common in the patient with the CVT. And finally, the symptom is usually slowly progressive. According to the study, the previous study, the symptom onset were acute, just 48 hours in just 37 of the patient, subacute in 56% of the patient, and the chronic over 30 days in the 7% of the patients. So let's say the most of the patients come to the hospital in the subacute phase from the 48 hours to 30 days. So here I summarize the proposed algorithm for the management of the CVT. So when you have the clinical suspicions of the CVT, so you need to take the patient to the MRI room for the MRI T2 star weighted imaging and MRV. So that means we can use the SWI to evaluate the hemorrhage of the patient, and the MRV to evaluate the venous side of the cerebral circulations. So when we have the confirmed diagnosis in CVT, So we can initiate the anticoagulations. You can use the UFH, unfractionated heparin, or you can use the low molecular weight heparin, your reference in your site. So that means when the patient have the heparin, the two sides will happen. The first one, the patient can tolerate to the heparin, and the patient will recover, and that means we will continue the optimal medical therapy. And the second option will happen when the neurological deteriorations and or coma despite medical treatment. What will we do? According to the algorithm, if the ICX happen and have the severe mass effect in the clinical and the imaging, we will consider the compressive hemicraniectomy. Or the other side, if the symptom in mind on the repeated imaging, we can consider for the endovascular therapy. On the next slide, we will talk about the treatment, the indication of the endovascular treatment. Like we see here, when the clinical deteriorations despite anticoagulations, and the contraindication to anticoagulations. And the third one is coma. Or deep CVT happen in the deep cerebral venous and ICH, intracranial hemorrhage. So we can start. The indication for the for the EVT. Here I summarize for 5 techniques using for intervene for the patient with CVT. The first one using the direct aspiration using an adaptive technique. The second one using the mechanical thrombectomy with stent retriever. And the third one is the direct thrombolysis with local injection of the thrombolytic agents like RTBA. The fourth one is clot disruption with angiojet irrigation. And the final is the mechanical suction with balloon stabilized aspirations. So this is the 5 technique we use in this case series. The arterial and the venous access we use in the most case 1 sheet in the arterial and 1 sheet in the venous. On the venous side we use the AF, and on the arterial sheet we use the 5F. The 5F arterial sheet is typically sufficient for arterial access to perform diagnostic cerebral angiography, and the AF venous sheet for the intervention. The pharmacological thermolysis, we can use the local intrasinus or bolus of the thrombolytic agent. And the direct aspiration thrombectomy, we use the large bore distal aspiration catheter like Sophia, like Titan, like Jet 7. And we can use along or in conjunction with stent retriever thrombectomy, as the next case we will present. So we talk the practical practice. This is the first case. This first case using the optical medical therapy. This is the patient, female patient, 41 years old, admitted due to diffuse headache. And admission, when the admission, the patient is conscious, no hemiplegia, no vomiting. And you can see here on the left side is the MRI, and on the right side is the 3D. On 3D we cannot see the lateral sinus, and most of the venous flow is come to the deep side to the heart. And this is the white sagittal. We can see here the clot in the middle of the superior sagittal sinus, the triple S. And on the thin sagittal, you can see here the flow is not fully, but partial can flow to the heart, out of the brain. And on the left side is the SWI. On the SWI, there is no hemorrhage. Yes, and on the right side is the SWI sagittal plane, no hemorrhage. So this patient, we do the optimal medical therapy. So the discharge status is the patient is still conscious, headache is improved, no hemiplegia, no vomiting. The medication using rivaroxaban, 15 milligram, 1 tab PO per day, and follow up after 3 months. MRS is 0. So talk about the next case. If 43 female patient with a headache missing because admitted to the hospital because of diffuse headache, nausea, vomiting, and NIHS is 0. And the past medical history is using the oral contraceptive over 6 months. And the patient have the adenomyosis with the hypermenorrhea and anemia. For the treatment, the patient used the Lovenox, that means enoxaparin 0.4 milliliter, 1 vial subcutaneous for BID and for 7 days. And for the adenomyosis, the patient performed embolization by EVT for adenomyosis. So on the left side, you can see the SWI with no hemorrhage. And on the right side is the MRV. You cannot see on the MRV is the occlusion of the half posterior of the triple S. And then when the patient discharged, there is the MSCT scan show no hemorrhage. But if you cannot, you can see the clot still in the triple S sinus. And the status when the patient is discharged is conscious, no hemiplegia, no more vomiting, and very mild vaginal hemorrhage. So the discharge medications, we're using the rivaroxaban, 50 milligram for 1 tab PO for 3 days, and follow up after 3 months. MRS is 0. So this is the example for the optimal medical therapy. But the next 3 cases, we want to introduce the more severe patients. The first one is the 43 female patient admitted to the hospital for the severe headache, and with a Glasgow scale is 14 points. With the left hemiparesis 2/5 and dry mydriasis for 3.5 millimeter, and past medical history for oral contraceptive. So here you can see on the left side show the SWI have the hemorrhage on the right side temporal lobe, and MRI show nothing happened, nothing abnormal. And on the MRV showing nothing much, and the SWI, and here is the DSA. The DSA is show no flow on the right side lateral sinus, and most of the flow come from the right side of the cerebral is take to the left side. And when we take the venous DSA, they're showing clot in the lateral sinus. Then on the left side we use the spider FX5. That means the embolic protection device, using on the right side to thrombectomy, and on the right side we use the balloon with the balloon is 4.5 over 120, and this is the PSA after balloon PTCA. On the left side post PTCA, we can see the clot still there, but the flow is increased. And then we try to thrombectomy by adapt technique using the Sophia plus 70. And then this is the final DSA showing the recanalization on the lateral sinus flow to the sigmoid on to the heart out this brain. And the patients, you can see here in the on the left side a MSCT 1 day, and on the right side 1 month later. And discharge status is conscious, no hemiparesis, mild headache, equal bilateral pupil, and medication we still use the rivaroxaban 50 mg 1 tab per day, and follow up after 3 months. MRS is 0. The patient can take care by herself independently. The case 4 is 47 patient, female patient, admitted to the hospital for the antemental status. And when they admitted to the hospital, the last goal is 12 pounds with the venic aphasia, with the right hemiparesis 3/5, and with the past medical history for oral contraceptive. And on the top of the slide, you can see the hemorrhage on the left side temporal lobe, and on the right side is the MRV. So when we do the DSA, show no flow in the left side lateral sinus, and with the venous DSA show the clot in the sigmoid, and then we take the DSA in the venous phase. So we can see here the clot is over the sigmoid and the lateral sinus. And then we decided to use the balloon to do PTCA. And when post balloon, we can see the flow can go to the lateral sinus. You can see on the point in the labe vein. And then we decide to use the bigger balloon. And on the right side, you can see the flow can take from the lateral sinus to the sigmoid sinus. And then the final showing the recanalizations on the lateral sinus to the sigmoid. And here the MSCT of the patient when discharged, still hemorrhage on the left side, but the status need to transfer to another hospital, and after 3 months when we contact to the relatives, the MRS of the patient still 0. She can take care of herself by herself independently. And the discharge medication given to the patient still use the rivaroxaban 50 mg 1 tab per day. And we talk to the last case. This case is the 43 patient, female patient, come to the hospital for the antemental status with the Glasgow scale around 11, with the right hemiparesis, 4.5, and central facial palsy on the right side, with past medical history for the oral contraceptive and the high hypertension. With the left side, we can see the why we have the hemorrhage on the left side of the frontal lobe. And on the sagittal plane, you can see in the S.I.S sinus, there's a clot there. And on the MRV, you cannot see. We cannot see the S.I.S flow. Then we decide to do the DSA for the patient, which show DSA show review no flow in the S.I.S. And then we use the thrombectomy with the Cerebral technique using the cut view V35 with the stent driver and the Sophia plus 6F. And then we use the adapt technique to to aspire the clot to outside. And then you can see the partial flow on the S.I.S. There's the clot there, still there, in the middle of the S.I.S. And then we decided to use the balloon, 6 Kronos 6 120s. And then we can see the flow can go through the anterior to the posterior and go to the lateral sinus, outside, go to out of the brain. And then this is the final results of the patient using the DDSA with the fully recanalizations on the triple S flow and on the MRCT showing. Yes, there is just very mild hemorrhage on the MRCT 1 day later, and when the discharge, the patient still conscious, right hemiparesis on the 4/5, fully orbit command. And the medication we use the dabigatran, 150 milligram, 1 tapio BID, and follow up after 3 months, the MS is 0. So 5 patients with the CVT, we do the EVT with the MS, 3 months later is 0. We think about the review previous documents, and we think about the TUAC trial. This trial is the RCT trial and just published in the last year, 2020. And to our knowledge, the TUAC trial, the first RCT on the efficacy and safety of the EVT in a patient with CVT and at high risk of bad outcome. And the neutral results of the TUAC trial should not be interpreted a definitive proof that EVT is not ineffective in the CVT because of the last reach of the 95% of CI indicated cannot be excluded the treatment effect of the EVT. We can think about the patient in the coma status. This kind of patient can take benefit from the EVT treatment. And then cerebral venous thrombosis is rare, potentially life-threatening disease, presenting in a variety of the ways. And mostly the patient come to the hospital in the late phase. So the treatment can be delayed. Yes, and the diagnosis and treatment involve collaboration between clinical and radiological team with a high awareness of clinical sufficiency. So thank you for listening to my presentations.